Candidate 1, please request control.
Sorry, sir, I'm still in work.
Yeah, no
So
problem.
I have to ask you to
Okay,
scroll
this
for
is
me, please.
20-year-old female patient presented with a history of 3 days of persistent numbness and weakness in the left arm. She underwent CT. Please, candidate 6, make 5-minute timing, and at 4 minutes, tell us there are 1 minute remaining. At 5 minutes, tell us finish. Okay? Okay, candidate 6. Hello?
Yes, yes, Dr.
Yeah?
Ravi.
Okay.
आपने हेडिंग का हमारे ब्रेन
Again?
विनोग्राम हमारा ब्रेन विनोग्राम भी
Mute yourself, my colleague, except the candidate in the hot seat. Dr. Ali, let's start. This 20-year-old female patient complaining of persistent left arm weakness. Go on.
Yes, I have been presented with axial images of a brain CT scan without IV contrast for an adult female patient. I will scroll until the last cut and then I will comment on my observation. Okay. This is non-contrast study. I noticed that there is cortical density seen within the right cerebellar hemisphere. If we can scroll down, I can see that there is, there is also density seen within the interhemispheric fissure, especially in the anterior aspect. Can we scroll down better, further? Yes, here on the right side, on the parietal lobe, I can see that there is tubular dense structure is noted, which in comparison with the left side, I cannot detect it. I want to scroll further to the base of the skull. Okay, I can see that the ventricular system appears normal, no shift of midline structure, and I can see that okay, here there is no crowding of the area of the foramen magnum. I want to correlate with the sinus. I cannot see any hyperdensity within the both sinuses. So there is also no brain herniation, no hydrocephalus, and there is no hematoma. Appearances are mostly those of cortical vein thrombosis without any hemorrhage or other complication. In my routine practice, I will see if the patient is still within the department. I will go further to do CTV, and if available, I will go for MRV to assess the venous system of the brain and to assess for any thrombosis. This is the post contrast images. I think this is a CT angio for the same patient, or the venous phase, because I can see there is enhancement within the cortical veins. I will scroll through the images. I will correlate with the cortical vein I noticed in the pre-contrast study. I can appreciate that there is filling defect within the superior sagittal sinus. This is suggestive of superior sagittal sinus thrombosis. I will continue to assess the extent of this thrombus. I can see that the cortical vein is also not showing any enhancement, representing cortical vein thrombosis. I want to see the rest of the sinuses, including the internal cerebral veins, straight sinus, and here I can see that there is no filling defect within the venous system so far.
So what is your next step?
my
What is your
my
next step?
my next step, I will urgently pick up my phone and communicate with the emergency department or the referral doctor, and I will combine my finding urgently, and then urgent referral to the neurosurgical and vascular team for anticoagulant and possibility of mechanical thrombolectomy.
What is the expected underlying etiology?
most of the time, the hypercoagulate status, because this is female patient, it could be due to pregnancy or postpartum.
4 minutes now.
Okay.
Uh, Other underlying cause, it could be due to hemoglobinopathy. Sometimes in older age, it could be underlying cause of malignancy. Other causes, it could be due to the thrombus elsewhere within the body.
Okay. From the CT scan, could you think there are any underlying cause here?
I will check.
Yes.
I'm
Hello?
checking the
Yes.
images to see if, can we go to the mastoid? I want to check the mastoids and the sinuses to see the
5 minutes
mastoid, the
gone now.
Thank you, Doctor,
clear,
so
and
much.
the
Thank you
thank you.
so much. You did very well. What happened here, my colleague? Take 2 or 3 advices. See, you did very well when you asked me to scroll till the end. I stopped here until you give me the request, so I go up. But here, the main density in the superior sagittal sinus. This is very important, and few surrounding cortical veins. After you mention this sign or description, you must follow it by your differential. Okay, doctor, this is hyperdensity in the cortical veins and the superior sagittal sinus. It almost represent a venous thrombosis. Then you go down and exclude or search for other signs or complete your exam. Okay, you go down and why? Because you go down and describe everything, and after that you come back and told me your differential. Okay. Second point, while you are searching your city, you must also tell the examiner, doctor, the mastoid and both middle ear are clear, the sinuses are clear, so there are no local infection. Okay, even there are no any brain or dural collection or infection like this. So you smashed the case completely. Why? Because you wait me until I ask you about 2 questions. First, there are any local etiology. Second, there are what is your management. Third, what is the other causes? Your answer, all answers were excellent, but the timing of your answer you shouldn't wait the examiner wait until the examiner asking you. Okay, you should give one by one by one. Like this is the best performance in the RCR, dural venous sinus thrombosis. You can mention this is MRI. You can tell the examiner. I forget. Anyway, this is, by the way, also this is not post contrast CT in venous phase. This is venography, CT cerebral venography, but without 3D. I think if I presented or if this case presented with 3D reconstruction, you will immediately tell me, doctor, this is CT venography. No, this is CT venography, but without 3D reconstruction. Okay, why? Why? Because why the examiner will give you a post contrast CT in venous phase in brain. Okay, this is venography. Look here, doctor. See, CT venography. Did you see it? Can you see it? CT venography. Anyway, you did very well.
Yes, I can.
You did very well. This case can come as a startup case because it is clear and it is very good case for training. Thank you so much. Next candidate. Next candidate.
Hello, sir. This is candidate 2.
Yes, doctor, request control, please.
Okay, let me just request control. Sorry.
Okay, I can scroll for you if you don't have. Okay.
Yeah, I have requested.
Doctor, this is 50-year-old male patient arrived in emergency for weakness of the upper limb. Go on.
Okay. So I will just scroll through the images. This is CT scan brain, axial images, non-contrast. Patient has presented in emergency with weakness of the upper limbs. Okay. So scrolling through the images, I could see there is a hyperdensity seen within the right part of MCA. Okay. And I don't see any evidence of intracranial bleed. There is no crowding of the cerebellum or foramen magnum. And I'm just trying to point out any obvious abnormality. I don't see any. Okay, here I can see there is a subtle hypodensity, which
Okay.
is present in the right uh, frontoparietal region. It is subcortical. I don't see any associated hyperdensity or hemorrhage. There is no midline shift, no ventriculomegaly, and there is some subtle loss of gray white matter differentiation as well. Since the patient has presented with limb weakness, I suspect it is a subacute or acute infarct. In my routine practice, I would like to have a communicate these findings urgently to the referring team and would require a neurological review or stroke team review, and MRI brain should be considered.
Okay. One
Okay,
second.
so these are the
Go on.
FLAIR images of MRI brain, which are showing FLAIR hyperintensity signal, which is present in the left parasylvian region. And also I can see there are some other hyperintense foci which are present in the either side, which I could see. In addition to this hyperintense signal in the left parasylvian region, there are other hyperintense foci as well in the left frontal and right region as well. So there is no associated mass spec. And can you have a look on the DWI images, if possible, please? Okay, so the DWI images are showing evidence of diffusion restriction. I would like to confirm it on ADC if it is
So the drug
showing.
is 4 minutes now.
Okay.
Okay,
So what's your final diagnosis, doctor?
so my final diagnosis in because this is a focal area of hyperintensity with diffusion restriction, which is present in the left. So it is likely to be an acute infarct. And it needs to be urgently communicated to the stroke team. And if the patient is presented within 4.5 hours window, it needs urgent thrombolysis or thrombectomy should be considered, and CT angiogram should be advised.
Okay, what is next investigation do you expect to be done for this patient, or will you suggest?
CT intracranial angiogram.
Please. This is angiogram. See, now you are presented with MRI, including this angiogram. Okay, so what else?
I think in addition to this angiogram, we can probably do MR perfusion
Yes.
images as well. Or
Thank you, doctor. You did very well. Your 5 minute completely finished now. You did very well. This is sure
thank
acute
you.
infarction. You did very well when you pick up this subtle finding. See, my colleague, this is the most difficult point here. The subtle finding is the main here. This one, this
Mhm.
right frontal,
Yeah.
okay? And
Yeah.
little bit here, there are some little hypodensity. Look, this is one, and this one, very subtle. So as I advise you many times, when you are presented with a modality, and sure, it must contain abnormality, and you expect you can't find anything, use the comparison technique. Slice by slice, compare this side with this side. Okay? Compare here with here. Okay? Go down. Ah, yeah. If you compare this side with this side, there are at least discrepancy. Okay? I lost one case in Viva, in last Viva that I passed the exam because it was X-ray. I compare and I have a doubt about discrepancy, but I didn't tell the examiner. Okay? If you have any doubt, tell the examiner because as you can see here, the cases is like that, very subtle. Okay, what else? He asked us to do this MRI. Okay, you did very well. This is MRA. What is the next exam after? If the examiner asks you this patient, you did MRI and MRA brain. What else? Next step. I'm not talking about management. This patient sure must be managed very urgently. But about investigation, carotid Doppler. If he asked what else, you
Right.
should do this one. What is this?
Carotid Doppler. Yeah.
After carotid Doppler. Why he is asking you what else after carotid Doppler? This is means carotid Doppler is normal. What else?
Mhm.
Echo. Why? To search for any source of emboli. Despite this patient
Emboli. Yeah.
is not young patient, he is a mature adult, 50-year-old.
50 years. Yeah.
Why? See, I think the
Yeah.
examiner will not show you echo, but if you look here, there are septal defect. This one, I think, this one. Okay, this one. Okay, this is the source of the employee here. Okay,
Emboli here.
right to left shunt. Why? Because this is
Right to
VSD.
left.
Okay. So at
Mhm.
least, at
Mhm.
least if he show you this one, at least you can have a doubt. You can guess patient with cerebral infarction. Okay, cerebral infarction, and the carotid is normal, and the examiner showing you the echo. So it must be something in the heart, like patent foramen
Mhm.
where I think this one, I'm not good in echo. I think this or this one. Anyway, the septum must be echogenic and must be completely patent. I think there are an opening
Mhm.
here, this one. Okay,
Thank you, Dr. Rami. Thank you.
welcome. Welcome. Next, see here, as I think in my knowledge in echo, see this one. If you see if you see like this flow in both sides, this is means a shunt, as I know. Okay. Anyway, at least if you didn't have any knowledge about echo, you can I think the examiner will just ask, and finally you can guess this. It may be neural thrombus, it may be myxoma, but this pathology are very clear. Or for any septal defect. Thank you so much. Embolic stroke due to patent foramen ovale. By the way, my colleagues, embolic stroke is very common to be associated with hemorrhagic transformation. Okay, thank you. Next candidate.
ايوه السلام عليكم. سامعني حضرتك؟
Yeah, welcome. Please in English. Can you request control?
I'm sorry.
Okay, don't worry.
From where?
See, this is 14-year-old patient complaining of, I will scroll for you, complaining of headache since 3 months. Okay.
Sorry again, the history.
40-year-old patient complaining of headache since last 2 months.
Okay. I'm presenting MRI T1 view, axial view of the brain. I can see multiple abnormal hypointense signal seen foci seen in both centrum semi-oval and corona radiata bilaterally. They are asymmetrical in shape. They have a central hypointensity. It has two
Yes.
intensities. This my routine. This maybe it's multiple lesions or multiple infarct area or infection. But as the patient has long history, maybe infection is not is less is a less possibility. My routine practice, I will review also the diffusion weighted image and the contrast study, T2 as well. The lesions doesn't show any
Yeah,
back
this is.
pressure, any mass pressure, mass effect.
Are you sure?
Yes.
This is T2?
Lesions are scattered all over the brain, showing amplified shape.
Mhm.
Metastasis and cysticercoid will be two possibilities.
Okay. How to differentiate?
The contrast study will limit the diagnosis. I will
What
urgently
else? What else other than
huh?
what else other than metastasis and
emboli infection. It
one
has
second, one
this.
second. Do you think employee are scattered randomly like this?
It's
Anyway, employee has a specific.
like it could be, but this long history
Yeah. Okay. What else?
is reducing the.
What else?
Hmm?
What else?
Sorry,
What else?
sorry, I can't hear you.
What else? What other
Uh,
diagnosis?
what else? Mm, other differential diagnosis rather than metastasis.
Yeah.
And so it
Hello?
could be of immunocompromise. Can you hear me?
Yeah.
No?
What? Yes. Tell me.
Hello?
Yes. Yes. Yes.
I said
Hello?
maybe maybe also like in
Doctor, your voice is so muffled. Can you change your location, please? Hello? Hello? Candidate 3, can you listen me? Hello? Okay, anyway, Candidate 3, you did very well. I think also we don't have enough time. It is about 4 minutes and 30 seconds.
Yeah, we still have a minute for this case.
Minute? Okay.
Yeah, 1 minute.
Anyone wanted to complete because I want to complete the discussion? Anyone?
Maybe candidate 4 can complete the case and
No,
take
no,
a new
keep
number.
keep candidate for anyone outside the candidate list. Anyone?
I can, sir.
Yeah, give me other differential diagnosis. She told us maybe metastasis, cysticercosis. What else?
It could be multiple tuberculomas.
Okay.
We need to look for the post-contrast image to just differentiate between
Yes, I think this is a post-contrast.
these lesions because
Yeah.
it could be also multiple abscesses.
Yes.
However, yes, but there is no surrounded edema and there is no, and it show show marginal enhancement with central hypodense core. So it
See, look,
could be
it's surrounded by mild edema. See all of this. See, it is edema. Edema. Why? Because
yes.
it is larger, larger than the size of contrast. So the rest of the high
Okay.
is edema. So what is your next?
Yes.
What is your next?
I want to look for the diffusion also to see if there is any restricted diffusion noted within
Yes.
it.
Okay.
Okay. Multiple diffusion, all the content show restricted diffusion, and also I want to compare it with ADC. If it's low in the ADC, so it's restricted diffusion, confirm it. It could be multiple abscesses. My main diagnosis for this would be multiple abscesses.
What history do you want to ask about?
I want to know if this patient comes with fever, if this patient has any
Fever?
previous infection.
Fever, no fever. What else? What other history?
If this patient, if there is no fever with this, so if there is any previous history for infection like
5 minutes now.
Thank you, but give her 1 or 2 minutes. Yeah. Okay, what else? What else? This is widespread random. Okay, you can consider abscesses.
It could be, yes, it could be random abscesses, could be
abscesses, random infection.
Yes, random infection. I'm thinking of endocarditis or something like this can cause, but
No. Endocarditis
no.
and all
Will
embolic,
cause
all embolic, all embolic pathology will have a nearly specific pattern of the distribution. What else? This patient, do you want to ask him about any history, any general history, any previous disease he have?
TB, but TB will cause multiple
If I told,
AIDS maybe.
yes, excellent, excellent. So yes, he have AIDS. So what's your differential?
The main lesions that come in with AIDS, TB could be TB, but
Yes. Why is this not? Why is it not lymphoma?
I believe that the lymphoma would be more than it would be masses, not randomly distributed.
What else?
And also it could be cryptococcosis. It could be toxoplasmosis.
Okay. But see,
But the toxoplasmosis also would be in the basal ganglia mainly,
yes,
and they would be multiple. But the cryptococcosis can be like this.
Yes. Thank you, Doctor.
Just these are the main infections that come in with the.
Tell me, what is your next step? What is your next investigation? Do you want to do this patient?
Next step for this patient. I really.
You have a doubt of TB. You have a doubt of TB. What
Yes.
next step?
Chest X-ray. I want to look for chest X-ray.
Acid fast.
And acid fast bacilli.
Thank you so much. Thank you, really. Thank you so much. Thank you. What happened here, my colleague, when you are presented with something widely spread like this, think about something horrible, especially in brain. Okay, she did very well when she talked about metastasis. The first, I'm talking about the first candidate. Okay, but the examiner asks, what else? What else means you should add more and more. What is your differential list? See, differential list in this widespread ring enhanced. This is the point. After the candidate asks for post contrast, now we are presented with a multiple innumerable ring enhanced lesions with random distribution. This is very important. So you must enumerate the different diagnoses. Number one, it may be lymphoma, but lymphoma almost preventricular and subependymal. So exclude lymphoma. Number two, toxoplasmosis. Okay, toxoplasmosis mainly basal ganglia. So we exclude two differential. So you have either TB, tuberculous abscess, tuberculomas, or cryptococcosis. Okay. During your discussion, you must tell the examiner, is this patient immunocompromised? This is very important. Why? Because it is very endemic in UK. It is very important in the consequences, either in the diagnostic or the management. So this question is very critical. Why? Many HIV patient may be discovered for the first time after this pre-MRI. Okay, very important. By the way, the difference between tuberculoma, anyone know how to differentiate between tuberculous abscess and tuberculoma? Anyone know?
I think that tuberculoma will not show restricted diffusion in the center, but it will show again
You
marginal
are very near.
enhancement
You
with,
are very, one second, you are
yes,
very near, but not restricted diffusion, something else. Look at,
the central core.
yeah, look at the center here in T2. Tuberculoma must be more darker. But if you
Yes,
concentrate here, it is almost fluid. Fluid. Okay. Abscess is
okay,
hard. See, almost generally. Tuberculoma, look at this dark point. Tuberculoma, all the center is dark. Okay. Thank you, doctor. So our
okay,
differential diagnosis may be lymphoma. I exclude toxoplasmosis, mainly basal ganglia. Okay. And biogenic abscesses, not tuberculous, but biogenic abscesses associated with fever and more larger. And as you know, the edema must be more marked. Okay. At least if you, for sure, if you ask about the HIV history or immunocompromising, TB will come in your mind immediately. Okay, my colleagues, again, this is disseminated CNS tuberculosis in the form of micro abscesses. Very important. The TB is very important. By the way, the feedback from January candidate were about all atypical cases. At least they presented with 3 from the 12, or I think 4 from the 12 cases. So atypical. So atypical case. Thank you so much. Next step, chest X-ray, acid fast bacilli is very important. Isolation of the patient. Okay, all of this information of the authority of community and preventable disease, all the known management steps. Candidate 4,
Assalamualaikum, sir.
welcome. This 10-year-old, thank you. 10-year-old male patient presented with nystagmus and poor vision. Go on.
This is axial MRI brain T1 weighted image of a 10-year-old patient who has presented with horizontal nystagmus and decreased vision. First, I will scroll through the whole stack of images and then I will comment about my findings. I will go till the last cut. So I can see on this axial T1 weighted image, there is a cleft-like indentation extending from subarachnoid space lined with gray matter extending up till right lateral ventricle. Along with that, I can see that there is altered shape of bilateral lateral ventricles. And in this image, I cannot clearly visualize the septum pellucidum.
Yes.
There is no midline shift, no mass effect, no
Okay.
crowding at foramen magnum. So to further evaluate these findings, I will go for T2 weighted images.
Mhm. T2. This is T2. I think this is T2. This is T2. Sorry, T1. Sorry, sorry.
This is T1, sir.
Yeah, sorry, sorry. Okay, go on.
On T2 weighted axial image, I can see that yes, this is gray matter lined defect in the right frontal lobe. So it's an open type of schizencephaly with altered shape, abnormal shape of bilateral lateral ventricles, giving colpocephalic appearance. And but I will review sagittal image to look for the presence of corpus callosum or if there is any um, partial agenesis. As I can see the anterior part of the corpus callosum, there is also absent septum pellucidum. So considering patient's history of decreased vision, I will also have a look on the optic nerves. Um, the optic nerves are not clearly visualized in this image, but I will review this in some other plane like in corneal images. So it's my first differential is septoptic dysplasia with open lip schizencephaly and coexisting neuronal migrational abnormalities. And I will also check the sagittal images for this.
Yes, sagittal. This is
Yes, sir.
sagittal. Okay, go on.
On sagittal flare, yes, corpus callosum is thinned for patients 10-year age. So there's dysgenesis of corpus callosum as well. Coming to the optic nerve, although T2 weighted image would be preferred, but um, I think optic nerves are relatively smaller in caliber. And
Mm-hmm.
other than that, I will also look for some other areas of heterotopia or neuronal migrational abnormalities. Um,
So what do you think?
So, sir, in conclusion, there are developmental brain anomalies that include septoptic dysplasia mainly with dysgenesis of corpus callosum and open lip schizencephaly.
Yes. What is your next step?
Sir, I will refer the patient to pediatric neurology for further management.
Okay. What's the type of schizencephaly? Do you know?
There are two types, open lip and closed lip. In open lip type, there is communication of the gray matter lined cleft and it is communicating with the lateral ventricle. And in closed lip type, it is confined to the cortex only.
Okay. What is this?
Here I can see there is volume loss. So this is likely an area of,
Yes.
yes, sir, an area of, I just want to see, yes, it is communicating porencephalic cyst,
Borencephalic.
porencephalic cyst formation.
Are you sure? Leave the mouse 1 second. Are you sure this is borencephalic cyst?
Mm.
I think
So
it is
say there is some, yes,
communicated with schizencephaly. Anyway, you see, it is
yes,
communicated.
sir. Yes, it's communicating with the ventricle also.
Okay, at least it is a component or a part of the anomaly here. Why?
Okay,
Look here. Sorry. Thank you so much, doctor. You did very well.
thank
Uh,
you, sir.
our candidate is very intelligent. Why? She didn't confuse or she didn't tracked by the lack of research. See, here it is part of the open cleft scientifically. You can consider it as subarachnoid cyst. Okay, no problem. But boring cephalic, no, I think because it is extra axial. Anyway, she is very intelligent. Why? After she discovered this one, she didn't stop searching for another anomaly. She just noticed that there are no septum pellucidum. So immediately she go to the optic nerve. The optic nerve is very thin or not well visualized. in both sides. So she put a very nice diagnosis of septo-optic dysplasia. I think this case may be in long, maybe in short, because it has two, you can smash it within 2 to 3 minutes. Very nice, very important. We have closed lip schizencephaly and we have open lip schizencephaly. Thank you so much. Next candidate. Next candidate.
Yes, sir.
Yeah. Doctor request control.
Yes, sir.
Now, 10-year-old female patient complaining of seizures.
Okay, so I've been provided with axial T1 weighted images of MRI brain of a 10-year-old female who has presented with left-sided focal seizures. I will go through the entire stack of images and then I will comment on the positive findings.
Yes.
So as I'm going through the images, I cannot see any evidence of hydrocephalus. The corpus callosum is intact and well visualized. Um, there is
Raise your
there is
voice.
some
Doctor.
sorry, can you hear me now?
Yes.
Okay, I can see that there is some cortical swelling noted in the lateral aspect of the left temporal lobe. However, there is no significant mass effect or sulcal effacement. I'm going down to see if there is any additional abnormality that catches my eye and could be related to seizures, which I don't see. So I would like to look at this particular area on flare sequences, if available, to see if there is any blurring of gray-white matter and any underlying white matter hyperintensity, particularly in the lateral aspect of the temporal lobe. Other than that, I do not see any evidence of nodularity along the ventricular walls. No abnormal signal is noted within the white matter to suggest any heterotropia or abnormal position of the gray matter.
Yes.
So can I? Yes, sir.
Yes.
So I would be basically focused on looking for any organic lesion which could be related to seizures. So I do not see any evidence of on this provided image of any uh, ependymal, subependymal hematomas, any mass lesion at the foramen of Monro, and I also don't see any significant um, migrational abnormalities. I do not see any schizencephaly, any porencephaly. And so can I look at the flare images?
Flare.
Yes, sir.
1 second. Can I help you? 1 second.
Yes, sir.
This is flare. Go on.
Okay. Okay. So I've been provided with coronal flare sequence, MRI brain, and I can see, I want to scroll towards the temporal lobes. I can see that there is some hyperintensity involving the right hippocampus, and there is no significant volume loss, and there is no significant prominence of the temporal horn. So this could represent mesial temporal sclerosis, which could be, and the hyperintensity and the increased volume could be because of the recent seizure episode.
Show me, please,
I do not see
by the mouse. Show me by the mouse. Where is
this
where is the temporal sclerosis?
this area
This area?
as compared to this
No.
area. Or alternatively, if I retract my statement, this could be that this portion is it has become atrophic or reduced volume.
Where is the exact location of diagnosis mesial temporal sclerosis?
So this area, the hippocampus and the parahippocampus. This part is, and I suspect this is normal volume. This part I think is reduced.
Yes.
This part.
Okay. So, what is the criteria?
So I will also look at the memory bodies and the fornix because they also show some. I can see the memory body over here is reduced in
Yes.
volume as compared to the left side,
And
and the fornix
what about the
also I
cornix?
can
Yeah.
see fornix is also reduced in volume. So this is right-sided mesial temporal sclerosis. I will convey my findings to the referring physician, and this could be treated medically. However, if there is intractable epilepsy, then possible surgical resection of this part can also be done.
Thank you so much, doctor. Very nice case, very rapid case. What happened here? This is the exact site to diagnose mesial temporal sclerosis. Where exactly here? When you see this mesial temporal loop, the hippocampus, and part from or the temporal horn. Why? Because the temporal horn, when this hippocampus reduce in size, this temporal horn enlarged. Okay, see? At least you can't see here obvious temporal horn in comparison to here. In addition to this bright signal in the hippocampus. Okay. Third, reduce the height or reduce the volume. Compare right by left. This is very obvious, by the way, case. Very obvious. Very obvious case. Look here. The height here is normal. He's abnormal. Number three, if you look here, the surface is undulated. Okay, here the surface looks like smooth. Three criteria: signal, surface, volume, or size. So our diagnosis is right mesial temporal sclerosis. Why this is very important diagnosis? Because this is the only treatable, surgically treatable cause of seizure. Very important. The neurosurgeon makes some like incision or something, some surgical procedure which helps the patient too much. Thank you so much, doctor. Next candidate.
I'm not sure, is it candidate 6 now or still candidate 5 didn't take a turn?
I think candidate 5 or 6.
Candidate 6.
Yeah, candidate 6.
Okay, then it's my turn now. Yeah.
Yeah. We will give you
All right.
60 minutes, doctor, not 5 minutes, okay?
Okay.
Control. Request control.
I request now. Okay, so this is 20 years old female patient with polyuria polydipsia due to diabetes insipidus. Okay, so these are sagittal, so these are sagittal cuts and T1 weighted images. I think it's a pituitary scan, not a brain scan.
Yes.
I'm going to concentrate on the area of interest here, the cella area. I'm sorry, am I moving it or is it?
Yeah.
Yeah, here it is. Okay, so I can see here, it's just jumping a bit, I can see the posterior pituitary here appears to be enlarged compared to the, I'm not sure if this is the posterior pituitary or this is the whole pituitary gland. So, okay, so the pituitary gland doesn't look to be bulky in appearance. It looks average in size for that age. I'd like to review this is the posterior pituitary here. This is the hyperintense part of the pituitary gland. I'd like to review the post-contrast images to see if there is any delayed enhancement or delayed actually hypoenhancement of a microadenoma. Just in the interest of time, can I move to the contrast scan?
Yes.
Yeah. So, yeah, I'm scrolling here. So there is diffuse enhancement of the pituitary gland, and I can't really spot an area of hypoenhancement. Maybe in coronal views it could be more obvious. I'm suspecting this area here, but it keeps jumping. This area here. Can I view the coronal images, please? Yeah, these ones.
What do you think?
Yeah, so, I think there is heterogeneous enhancement of the gland here. Some areas are hypoenhancing compared to the rest of the pituitary gland. However, the volume of the pituitary gland, I'm trying to figure out if this is a macroadenoma because on sagittal images it didn't.
What
Yeah,
else?
the pituitary gland looks of average size.
What else?
However, the stalk of the pituitary gland looks a bit bulky.
So
Yeah, this bulky stalk. Yeah. I was expecting to see, honestly, to see a hypo-enhancing nodule within the gland. So but I couldn't really identify it obviously in a confident way.
what's your diagnosis?
So my diagnosis is most likely a microadenoma within the pituitary gland. I couldn't spot any other abnormality. The gland size is normal. There is no invasion of the adjacent cavernous sinus on both sides.
I
Yeah,
will
so
I will help you. See what happened here.
the teacher. Hmm.
Tell me what happened. The answer in this slice, in the first slice.
So I can see this is bulky. Usually the pituitary stalk is usually more
What does
thin
it
than
mean for
this.
you? Okay, what does it mean for you?
It means hypophysitis, a sort of hypophysitis, which could be either inflammatory or granulomatous hypophysitis or
Yes,
eosinophilic
what
granuloma
else?
in young age.
Yeah, excellent. What tell me there are another very important finding here. Very important.
Um,
You told me there are nodular thickening of the stalk. What else? And do you have a
yeah.
doubt of a specific disease? What else? There are another finding.
Um, I'm sorry. I cannot really connect the
Usually
dots, but
in T2, usually in T2, in
mm,
T1, there are anterior and posterior pituitary. What do
oh
you
yeah.
expect about the
So there
posterior?
is ectopic pituitary here.
No, no, the pituitary. This is the posterior pituitary. What happened for the posterior?
Yeah, it's low density, low intensity compared to what it's supposed to be like.
Excellent. What is the name of this sign?
Um, no, I can't recall it to be honest. I'm sorry.
Okay, it must be high T1. So there are absent
Yes.
T1. Okay, absent
Mm-hmm.
T1
Mm-hmm.
of the posterior pituitary. Okay, plus nodular
Mm-hmm.
stalk. What does it mean for you? Are you still insisting in micro or adenoma or
No,
something else?
it's hypophysitis. Yeah, I think it's
Yeah.
hypophysitis.
What
Something from
else?
yeah.
What else other than hypophysitis?
Is it hypothalamic hamartoma?
No,
Usually the
no,
presentation
no.
is not diabetes
No, in
insipidus.
hypothalamic hamartoma, you will find a normal T1 high signal of the hypophysate or
Mm-hmm.
the pituitary.
Mm-hmm.
What else? What are the causes of loss of normal high T1 of the posterior pituitary?
Adenoma, microadenoma of the gland,
No,
or
no. What else? The most common. You told me hypophysitis. Okay, excellent. What else?
hemorrhage,
Some relative to hypophysitis. What else?
relative.
Yeah, something very.
Uh,
Okay, don't worry. What is the association
I'm
of
sorry.
hypophysitis?
Yeah, granulomatous hypophysitis. It could be a TB hypophysitis or sarcoid. Sarcoids, just like
Yeah.
the
Okay.
comment
So,
I just read
so
now.
lymphatic hypophysitis, granulomatous,
Yeah.
like this. Okay. I
Mm-hmm.
think also Toulouse Hunt may be added. Anyway, what is the association of this autoimmune disease?
Um, no,
Hypophysitis
I'm sorry.
is a component of generalized, very common
Yeah,
autoimmune disease. Causes
yeah, it's
retrocirrhosis,
fibro.
pancreatitis,
Yeah, sclerosis. Yeah.
not sclerosis.
Mm-hmm.
IgG4.
Yeah, so it's
IgG4.
yeah, IgG4 disease. Yeah.
Okay. See, this
Mhm.
is lymphocytic hypophysitis. What happened here in lymphocytic hypophysitis? There are loss of normal T1 of the posterior pituitary, like we see, and maybe nodular stalk. This is maybe associated
Mhm.
with other autoimmune diseases, especially other autoimmune in general. And see, the hypophysitis is a general term. There are lymphocytic hypophysitis or IgG4 hypophysitis. How to
Okay.
differentiate
Mhm.
pathologically by the pathology. But you must enumerate
Mhm.
to the examiner. What is the association here or your differential diagnosis? It may be associated with Toulouse Hunt, okay, and or
Mm.
tumor of the orbital. What else?
Mhm.
What else? You must talk a little bit about the
Thyroid
IgG4.
gland. Yeah.
Is a differential diagnosis here? Okay, pituitary adenoma. But in pituitary adenoma, especially the picture is totally different from contrast and from pituitary adenoma. You will not see. See, you must bring this T2 and you must see
Mm.
here in both sinuses. Here,
Yeah.
here and here. Okay, this is
Mm.
this is not the ideal case to talk about dark signal here. Okay, honestly,
Yeah.
not obvious, but this is the differentiation between macro or micro adenoma and the hypophysitis. Anyway,
Mhm.
IgG4 related hypophysitis or granulomatous
Okay.
hypophysitis, either sarcoidosis or syphilis. Okay.
Mhm.
Again, what happened here? This is autoimmune inflammation here, or it is
Mhm.
a bulkiness of the stalk and abnormal loss of the signal here. Please put whatever possible of your differential diagnosis. Okay, we are not here a
Okay.
pathologist.
Mhm.
If you tell the examiner adenoma, hypophysitis, including the three common type, lymphocytic hypophysitis, IgG4 hypophysitis, or what else, granulomatous hypophysitis, the examiner will be very happy.
Granules. Mm.
Thank you, doctor. It is very
Mhm.
difficult case. I think you are very
Thank
happy
you.
from the beginning because I give you very clear history, correct?
Yeah. Mm.
It's a
Yes, true.
it is too much sophisticated. Don't worry.
Thank you. Thank you
Dr.
very
Ali, did we
much.
finish?
Sir, we have only one candidate left.
Okay. Uh, yes, join please, my candidate.
Candidate number 7. Yes.
Yeah.
Join
Here,
please.
sir. Can you
Well,
please scroll for me?
yeah, doctor, this patient
Okay, thank
has multiple neurological symptoms along the last 3 months.
Okay, so I've been provided with the MRI axial sequence, FLAIR sequence of brain, in which I can appreciate that there are multiple areas of FLAIR hyperintense signal abnormalities with internal punctate low signal foci, predominantly in the left frontal, temporal, as well as parietal lobes. Some other smaller areas are appreciated within the right periventricular, as well as
What
the
does it mean?
temporal lobes.
What does it mean for you?
So I'm thinking that this is a multi territorial type of
Excellent.
involvement
Excellent.
by the process. And okay, so these are the diffusion weighted images in which I can appreciate that there is another focus of diffusion right signal abnormality within the right side of the pons as well as the right basal ganglia. And the previously described lesions, they also show diffusion right signal abnormality. I would confirm them on ADC whether they are getting low or not.
Yes,
And
you see, most of them confirmed except this left-sided. Hmm.
yeah, so I can appreciate that they are not becoming that low. I would like to see the okay. So uh, they did not become that.
low. So I think they are, this is facilitated diffusion. And further, I would like to see if there are any post-contrast images to, uh, I would also like to see the T1 weighted images because I
No,
could see that
concentrate
T
here.
contrast ones.
Concentrate here, please.
So, okay. So I've been provided with post-contrast T1 weighted image in which I can appreciate that there are nodular areas of enhancement within these lesions and within these areas, and they are basically in the, like the left one is within the MCA fissure and then extending into the Sylvian fissure. And basically they are extending along the subarachnoid spaces.
What's
And
your diagnosis?
so far, I would be thinking of disease process which is involving the leptomeninges,
Excellent.
which would include leptomeningeal differentials would include if there's any known history of prior malignancy, leptomeningeal carcinomatosis would be one differential. Another differential could be of granulomatosis disease process like sarcoidosis. However, it usually involves the skull basis. Apart from that, uh,
Yeah.
yeah, so I would like to convey my findings to the referring physician, ask for any prior images or if there's any known malignancy,
What's your
which would.
interpretation for this flare abnormal signal? You give me, by the way, half of the answer because half of the answer in the post contrast and the other half on rest of the image, especially here in flare. What do you think?
Okay, so I think the abnormal signal is also extending in the subarachnoid space at this level, apart from the cortex. Uh, so, uh, uh, and this did not show any diffusion restriction. So, I'm
See,
thinking that.
now you told me there are granulomatous disease, and I agree with you. What's your
Okay.
explanation for the finding here?
Okay.
Multiple
So.
wedge shape, I will help you. Multiple wedge shape signal abnormality. Some of them are restricted, some of them are not restricted. What does it mean?
So there's some kind of underlying thromboembolic phenomena which is causing infarcts of variable ages alongside this
Okay,
disease process.
okay, so what's your final diagnosis?
So findings are most likely in keeping with granulomatous disease process like sarcoidosis with
Complicated by?
uh,
Yes, excellent.
or
Look here.
sorry.
Look here.
Yeah,
What?
so yeah, I was about to, yeah. So I can appreciate that the the MCA is significantly narrow calipered. So there is element of vasculitis underneath,
Excellent. Excellent.
and
Thank
which
you.
is resulting in these infarcts.
Very important, Michael. Very important. This is another case of to be totally different from the first case. Tuberculous meningitis complicated with vasculitis. I will give you very important tip when you see it. Multiple territorial or wedge shape, cortical and white matter lesion like this, multiple. One, two, okay? And the other here of different age, see? Of different age, think about vasculitis. This is very clearly, this is infarction. But what else? What is the underlying? By the way, doctor, this is not a thromboembolic. Why?
Okay, fine.
Thromboembolic, thromboembolic, not
We
well.
are mainly in the watershed zones, I guess.
Yes, yes. Watershed zone, number one. Number two, it's thrombi, any blood-borne pathology like these areas. The
Okay,
junction
fine.
between cortex and white matter overall.
Okay, fine.
Okay. Second, do you think this patient will be left for this long time for this embolic showering? See, one infarction in one here, okay, and
Yes, okay.
other one here, okay. So vasculitis, keep vasculitis, my colleague. Even if you
Mhm.
insist to talk about thromboembolic disease, okay, but vasculitis is very important, especially if you go down and after I showed that this
Hmm.
nodular enhanced. See, not only nodular, there are ring enhancements, very
Yes, and
characteristic of
punctuosa as well.
tuberculomas, very characteristic here.
Yes.
If you concentrate in T2, this is, see, concentrate here. Do you think this is
Okay.
tuberculoma or abscesses? Very dark center.
Yes.
Very dark center. This is tuberculomas. Okay.
Okay, right, sir.
So this is tuberculous meningitis complicated by vasculitis, and the vasculitis causes infarction. Okay, multiple of different age. How can we know? We must compare here. This one. Sorry, this is the last case, but very important, by the way. What happened here? In acute infarction, the ADC is very dark, and the DWI is very high. Okay, like here, this one. I think this one here. I think here dark. Okay, after few days or 2 weeks, the ADC start to be more facilitated, and the
Mm.
DWI start to be less bright. Like this. This is subacute. This one and this one. Okay. And with the time it start to be more fluid here, more fluid up to forming encephalomalacia containing CSF. But this is very chronic stage associated with volume loss. Why I'm insisting this is not this is almost subacute, because look at the volume loss, very important also to help you. Look here, almost there are no mass effect and no obvious volume loss. No obvious. I think this is late subacute because the sulci here started to open. But and there are some very few cystic changes. This is very late subacute. Anyway, at least you catch the scenario of the case. Thank you so much for all colleagues. This is patient also HIV. Okay.
Mm.
Thank you, Dr. Ali. Thank you of all of you.
Thank you, sir.
Welcome everybody. Goodbye.
Thank you, sir.
Thank you. Goodbye.